here you have the causes. Causes are given in your book. You need not write. The genes are two of them. As you can see, they are SFTPB or TPC. Okay, so these are the two genes which are involved. Now this is what I was talking about. Thanks that we got it at the time. So you refer to the other side of the chart. That is what is your pathogenesis and how is it happening. So if the baby is, say there are a lot of causes, but say that the baby is premature, like less than 34 weeks, and the baby is born before that, then there will be definitely not much of surfactant. They will be ill produced. There will be reduced quantity of the surfactant. Okay. And all of that will cause what? It will decrease the alveolar tension. Like alveoli is supposed to expand after the baby has taken the first cry. It will not expand, the surface tension will be less. Because of that, they will be small in size, they will be collapsing. That is known as atelectasis, which is here. Okay. So atelectasis it can happen as a medical condition separately in any young adult. Could be because of trauma, could be because of infection, multiple things are there. But here we are discussing only about the surfactant problem. So because of that, the alveoli of the lungs will collapse. That is what is known as atelectasis. The lungs are just a sikud jana bolte. That is what it is happening over here. So because of atelectasis, definitely there is ventilation perfusion mismatch. Okay, rest of the thing is you can build up. Ventilation perfusion mismatch is there, because of which there will be pulmonary hypoperfusion. And what exactly is going to happen is the plasma will start leaking into the alveoli. So instead of getting oxygen, now fluid is filled inside the lungs. So this is what, if you can write the entire one, it's well enough. But the terminologies which I need in the answer book, or any of us will need, is there's a premature child, the surfactant is not getting produced enough. Because of that, there is reduction in the tension, surface alveolar tension. Because of it is going for atelectasis. Then the ventilation perfusion mismatch is there, and plasma is leaking into the alveoli. That is all we need there. Okay. So if something grossly is coming to us, we do not get such kind of specimen. This is not there because the child is dead, so it goes only for postmortem, and it does not amount for a biopsy or some kind of diagnosis. It's a clinical diagnosis. But still, if the death is inside the womb, then the lung will be lifeless. It will be airless. Okay, it will be heavy. If you put it in the water, I'm sure you must have read it in forensic by now, drowning and non-drowning cases. So it's the same thing. If you take lungs, you put it in a bucket of water, it will soak down, because it has never breathed air. Once there is air inside the lungs, it will float. Fine. It's just like a balloon. If inside the balloon there is air, it will float. If there is no air in the balloon, it will sink down. So the same thing happens if the child is inside the womb and it dies there, even before coming out of the world. The lungs is solid, heavy, and you put it is just very heavy, it goes down into the water. And if it is post this thing, like after getting birth, then it is a mixture of things. It can be solid if it has breathed something, if it has not breathed at all, and if some amount has been breathed, then it can be float on the water surface. So this is how it looks. It looks lifeless and structureless. And these you can see, these are the alveoli. Okay, normal alveoli, and these are the alveoli which are having this pinkish area. This is the plasma which has infiltrated into the alveoli. Okay. And these are the rest of it is all of the blood vessels. So even the blood vessels are have become prominent, and they're leaking around. So this is the histopathology. Histopathologically, you see plasma leaked into the alveoli. That is the diagnostic of neonatal RDS. Fine. Clinical features and all I have already told you. It's preterm baby. Write about that. Other than that, there can be definitely aspiration of meconium aspiration or insult during childbirth and all those things which is there. So just mention, it's an exhaustive list, but most common it is preterm. Then apart from that, the help, like if you have to do a laboratory investigation, it is the X-ray, which looks like ground glass appearance. This is again an MCQ question. If you are planning to write NEET SS or something, they do ask this thing, like ground glass appearance. Nowadays the straightforward questions are not there. They'll give you a history and you have to put up a diagnosis that it is RDS. And what is the prophylaxis? We just give we start giving surfactants to the mother, or we start giving cortisol to the mother before 28 weeks of gestation. Okay, fine. So this is just one thing. It is there in Robbins. What are the complications of RDS? They themselves are big topic which you will be reading in your third year, retinopathy of prematurity and bronchopulmonary dysplasia in medical. But right now we don't need much. You can just write this to complete your answer. Fine. Okay, and the prognosis is poor if the baby is not diagnosed immediately and treated. If you treat immediately, prognosis is good, babies survive. Like very nowadays we have such a high level of neonate ICUs that we can save them, at a very good age. Fine. So next topic is fetal hydrops. Now fetal hydrops, as I was telling you, that it is divided into immune and non-immune, and we are supposed to read the non-immune one because it is related to the cytogenetic abnormality. So this is nothing. Fetal is a baby, and hydrops is the entire body is getting covered with fluid. Okay, it's a baby which is swollen and it has got lot of fluid everywhere. There is fluid accumulation in the body. Now why this is happening, we will see. Immune is the one which is related to transfusion, so I'm skipping it because you have already read about it. We are coming down to the non-immune reason. Okay, now non-immune again is related to stillborn baby, okay, or premature delivery. Like these are the most common things, and if the baby is born and you're treating the person, the baby can recover completely. But if it is intrauterine death, so we cannot do anything about it. So the edema which is present can be the entire body is covered, or it is localized, or it is just an isolated edema, say only liver is enlarged or abdomen is enlarged, something like that. Now okay, first let me take it here. So this is how the baby is. This is actually like an IUD baby already dead. So this is the classic example of non-immune fetal hydrops. So what do you mean by the term non-immune? See, immune is when you have this Rh positive and Rh negative mother, father, and they have not taken that prophylaxis and the baby is born, so it is having that problem. Now non-immune is most of it related to stillbirth or some insult during the maternal pregnancy, like the mother is having some hormonal deficiency, or she has taken up some pills which she is not supposed to take, or during the delivery it's a cesarean section or forceps delivery or vacuum delivery which is causing insult to the baby. So these are the causes, like the feto-maternal causes are the ones which causes non-immune hydrops. And in that you get this kind of picture. The baby is grossly edematous or locally edematous, or some isolated like liver or lungs is edematous, something like that. Now when you take up a histopathology of any organ you want, usually in any organ we get what is known as extramedullary hematopoiesis. Okay, so the term extramedullary signifies you have it in thalassemia as well. So what is it? Wherever your marrow is, there only hematopoiesis takes place. But in such cases, the hematopoiesis can occur anywhere outside the marrow tissue. Okay, it could be in liver, it could be in spleen, it can be seen in the cheeks. Anywhere you take sample, you get them. So what do you get in that extramedullary hematopoiesis? You look for megakaryocytes. You're seeing these big cells, all these big cells are megakaryocytes. Okay, and some of RBCs are not seen here, and the rest of the red color cells are all blood vessels or blood cells, RBCs. Okay, so this is what it is about. These are not very big questions. This can be a 5-marker question. Phenylketonuria, RDS and fetal hydrops are not such big questions. They might be just asked in Viva or something. In this total scenario, you should know this phenylketonuria and cystic fibrosis. Okay, cystic fibrosis is an important question. So we'll first go to phenylketonuria. I don't know, maybe from biochemistry you can remember some of it, that this is basically related to an enzyme deficiency. This is the enzyme, okay, PAH, phenylalanine hydroxylase. It's an hydroxylase enzyme and it is phenylalanine, the end product. So it is phenylalanine hydroxylase, very simple to remember. And this is, see, just remember it by word that all the like inborn errors of metabolism are autosomal recessive, because if they are autosomal dominant, if the enzyme is completely absent, then it is incompatible for life. Okay, so the baby will never be born, it will die intrauterine itself. So always these conditions are autosomal recessive. It will be very easy for you to write down. Any inborn error of metabolism is autosomal recessive. Fine. So this is autosomal recessive. The gene involved is phenylalanine hydroxylase. Okay. The enzyme is phenylalanine and the hydroxylase is the enzyme. So pH is the gene. Now what is happening? First we'll see this. This is the reaction which is happening. If you can write this reaction well enough, if not the complete one, then just write this part of it. When it is like phenylalanine is acted upon by the pH, it produces tyrosine. That is all the reaction is, and it releases it uses tetrahydropterin biopterin for reduction to dihydrooctane. Okay, like a 4 molecule is getting reduced to 2 molecule. If you can remember, right, otherwise it's okay, just write this part of it. PA is getting converted to tyrosine by PAH. Very simple to remember, PA, PAH and tyrosine. Okay, so this is the enzyme which is acting here. When this enzyme is not acting, of course phenylalanine is getting stored in your body more than required. It is not getting converted to tyrosine. So tyrosine has its own function, right? And this is just a toxic metabolite. This has to be reduced to something productive. But this toxicity keeps accumulating in the body of the child, and that is what causes all the symptoms. So what are the symptoms? They are all here. This is from Robbins. You need not take a pic or something. So usually if you see, generally the child will look very, very characteristic. Okay, they will have this slanting eyes, they will have this something like a flat face, and they have this dysmorphic features. So the child, by seeing, you can tell. This is very, very rare, but still very common. Like imagine a child who is having it and the parents don't even know this is there. To get it treated also is a big thing. So it's best that you know, so that you can at least be clinically sound to diagnose. So this is the thing, and in them they have this self-mutilation as well. They keep on biting themselves, they get this itching sensation, or they are like obsessed, so they keep on biting themselves and try to mutilate themselves. Okay, this is one. Apart from that, you should remember like hypotonia. Okay, hypotonia means they are unable to maintain, like you guys are sitting, I am standing, we cannot, they cannot do that. They need support to sit, they need support to stand. So that is something like hypotonia. Next thing is, because it's a child, they will definitely have poor feeding habits, and like easy nausea, vomiting, all that thing will be there. Apart from that, if you can write this cherry red macula, it is one of the characteristics, though it is for other storage disorders and inborn error of metabolism, but still if you can mention the cherry red macula, it's fine enough. Okay, fine. So now the deficiency can be, it can be like the enzyme is partially deficient, it can be like it is entirely deficient. As I told you, entire deficiency is not possible, otherwise it will be incompatible for life. So it can be severe, mild, moderate or severe deficiency. Fine. Okay, so this is again the same diagram telling you that if the metabolite is not used, then what is happening. Now this is something screening. If you want, you can take a pic of this, because it's not from the textbook. You do not have to know everything. If you want, you can just remember the levels, that if it is more than 120, if you are suspecting a child who is having low IQ, has some peculiar facial features, and is not taking up feeds and having nausea, vomiting and diarrhea, then you should work up for something like all various differential diagnosis of inborn errors of metabolism. Out of that, if you, of course, you are doing workup for phenylalanine and you get a level which is more than 120 micromoles, okay, per liter. So if you are getting that, then you screen. Do not need to write the entire thing. You can just write that this is one thing which we do screening for, and we do the tyrosine ratio, PA tyrosine ratio, which is more than 1.5. Okay, that is more than enough. If these things are analyzed, apart from that, we can do the mutational analysis, pH. Okay, because this is a very short topic, so if you get for 5 months, you should have at least something to write. So write elaborately about the clinical features, because there are many. Then just write that reaction and tell that this is toxic, this is the metabolite, and at the end write this thing that for screening or diagnosis we use these things. So it will fetch you at least 4 out of 5. Okay, fine. Then another one is galactosemia. On the similar category, it's also an inborn error of metabolism. Again, as usual, it will be autosomal recessive, and there will be some enzyme defect in it. Okay, so what is the enzyme which is getting affected here? It is this one, galactose 1 phosphate uridyl transferase. Okay, GPUT if you want to remember, but still it is difficult, so better to remember galactose 1 phosphate is the the substrate, and uridyl transferase is the type of the enzyme. Fine. So this is the enzyme which is getting deficient here, because of which galactose 1 phosphate keeps on accumulating all over the body and causes all the clinical feature you are getting in the child. So the features will be again similar. There will be not much dysmorphic features, or the child will be not characteristic. These symptoms will be more of gastrointestinal. Like the child is throwing, vomiting, he is unable to eat, he is unable to, failure to thrive, he is very cachexic. These will be the symptoms. IQ and all are not much affected, like phenylketonuria. So here, that when such kind of GI symptoms are there, we rule out again whatever differentials we have, and we have one of this enzymes as the differential. Okay, so the screening is you do this fluorometric assay of the GLT enzyme. And how do you confirm is you see them in RBCs. Okay, red blood cells may you measure the GLT levels. That is the diagnostic or the confirmatory test. So you can just mention this. And say you are getting that the family history is there and the mother is susceptible. So in those cases, before the delivery or something like in the antenatal period, you can take the amniotic fluid cells or amniotic cells and you can culture them. These tests are very, very costly, so I think it is only limited part of the society which can do this. So regularly it is not diagnosed, and it is after birth only when the child is diagnosed of such cases. Okay. So this is the enzyme pathway. If you want, you can write this as well in the answer book, because if it is coming for some marks, then at least you have something to write. So it is galactose, which is getting converted to galactose 1-phosphate, and galactose 1-phosphate comes to glucose 6-phosphate, and it is here the enzyme is coming, galactose 1-phosphate uridyl transferase. Okay, fine. This you can just take a picture. This is defining what all assays you do. You did not remember the entire table. You can just list down these names. So what are the tests we are doing? Definitely we are doing the assay, the enzyme assay. So mention the name of the enzyme and write the assay. These are all the kinase enzymes. You need not write them separately. Just write the enzyme assay, that is one. Number 2, you can do a genetic analysis. Okay. Then number 3, you can do the galactose 1-phosphate, the substrate, that not the enzyme, the substrate, galactose 1-phosphate analysis. That is just to monitor if the treatment is progressing fine, because the substrate should be utilized then if the enzyme is working fine. So these 3-4 names is more than enough. You can write urinary galactosol quantification as well. Okay. Fine. So we'll come down to the main thing which is there actually, cystic fibrosis. This has got a lot of subheadings to it. So the small ones, RDS, phenylketonuria, galactosemia, expect only phenylketonuria to come as a question. Okay, like 4 marks, 5 marks, 3 marks, like that question. Cystic fibrosis can be a main question in itself. It has come in the previous years as well, sometimes in internal, sometimes in university. So why this is so important? Just take it from the name, like cystic and fibrosis. So like the child will not, you will not see the symptoms like by birth or something. It will, the child will be a bit older, growing up phase, like 2 to 5 years of age, when the symptoms are coming up. Sometimes it may not come out at all. It will come out in the adulthood, like 20s and all that thing. Okay, so we'll go to the details of it. So this is the genetic mutation. You have to remember. If you can remember the number, fine. Otherwise, just write CFTR gene mutation. Fine. It's a cystic fibrosis transporter mutation or something. CFTR mutation. Okay. And most common in Caucasians. Indians don't have it, thank God. So we are free from this. And yeah. So what is the defect in this cystic fibrosis? This is basically there's this channel, the ion transporter channel. It is sodium chloride ion transporter channel, which becomes defect. CFTR is the gene which is controlling this NaCl transporter channel, and because CFTR is getting affected or harmed or synthesized or like mutated or whatever, because of that the NaCl transporter ion is not functioning properly. Okay, that is the exact defect. What is happening here? Now what is the function of this channel? If you understand the normal function, then you will understand what is happening abnormally. So the transporter does what exactly is, it throws the chloride outside and takes the potassium inside. Okay, throws the chloride outside means it is making the fluid or the cell free of chlorine. Okay, there is not excess of chlorine when the transporter is acting normally. That's all you have to remember. Chlorine is less when the transporter is normal. Okay, and this particular transporter is very tissue specific. Like there are 2 examples here, and this is what is affected in cystic fibrosis as well. The first one is the sweat duct. In sweat duct, it is causing the chloride amount to come down from the sweat into the epithelial cells. Okay. So the channel here is functioning reverse. It is throwing the chlorine from the sweat glands into the epithelial cells normally. Okay, so you have the sweat ducts which is present, or the sweat glands which are present, and you have the sweat which is secreted into the lumen. So from the lumen it is transferring all the chlorine inside. That is the normal function of the CFTR gene over there, and the sodium chloride transporter over there. Got my point? Okay. So, and we'll go to the other normal as well. So in case of nasal mucosa or respiratory epithelium, the same channel, the same transporter is throwing the chlorine out of the cell. Okay, as I told you, this is very tissue specific. So the transporter ion is same, the gateway is same, this is the door. But this door in sweat glands is letting people come inside, and this door in the respiratory system is throwing the people outside. Okay, that is all it is about. So in case of respiratory epithelium or nasal epithelium, it is throwing the chloride outside. So now you try to understand what happens when there is a defect. If CFTR is getting mutated, then in the sweat duct what will happen? The chloride is not coming inside the epithelial cell. It is present in lots and lots of amount in the sweat. So the sweat of the child will be very, very salty. That is what the mother brings the child with a complaint of. She will be like, when I am kissing my child, his skin will be very salty. So she'll be like, why is he tasting like that? He's tasting very salty. It's like a salt, chloride. So she brings that. That is the presenting complaint of the mother who comes with the child. Okay, it's very, very normal. It's not like a very hi-fi thing that my child is failure to thrive, not eating, he looks weird, nothing like that. It's only that simple statement the mother is going to give, that my child is tasting very salty when I'm kissing him or something, when I'm pampering him. Why is it so? Okay, so this is because of this. So the sweat is having lots and lots of chloride because the transporter is not functioning normally. So the same thing which happens in the respiratory tract. What is happening? Chloride is being thrown out to the nasal, to the nasal secretions. But in that case, in the case of cystic fibrosis, chloride will be maintained inside the respiratory epithelium. So the nasal secretions do not have chlorine. Now chlorine over there, because it is a salt, it will pull water with it. Okay, this is normal osmosis. Wherever there is salt, water will automatically get transported to that part. It's by osmosis. So the respiratory epithelium will be very dry because chloride is not going there. So the respiratory secretions will be dried up. So the nasal mucosa of the child will be dried up. The respiratory epithelium, which has got the normal fluid maintenance, the fluid will be less. So he will have breathing problems as well. Okay, the manifestation can be very varied. We will see in the next slide. So this is there in Robbins. Don't worry about it. So there are some 6 levels the entire disorder has been classified into, depending on how the gene is, at which stage the gene is getting hampered. So all I would want you to remember is, let's start from the normal. Do not fall into all this entire thing and so many things. Just look at here that the first thing, the normal function is like the gene is maintained and everything, the chloride is going out and all the things are all the functions are normal here. Now here when it is grade 1, what happens? Grade 1 is the most severe one. Okay, remember it like that. Grade 1 is the most severe one and grade 6 is the least severe. So then you know that you have to go from severe frequency to least severe frequency or the very good frequency. Okay, so in between that 2 to 5 will be moderate intensity sort of thing. So grade 1, because it is so severe, the gene is absolutely not there. Okay, just remember that. There is no functional gene or there is no functional CFTR protein, whatever you can write it as. That is grade 1. Grade 2 is that the gene is there, but there is a trafficking defect. Like the protein is formed, the CFTR gene is releasing the CFTR protein and it is telling that go there and act, but the CFTR protein is not being able to be delivered at the transporter site. So it is known as trafficking defect, that it is not going and reaching the transporter. So it is grade 2. So grade 2 you have to write that there is CFTR protein trafficking defect. Okay. Grade 3, so definitely this will be less severe compared to the no protein present. Now grade 3 is CFTR is there, it is getting produced appropriately, it is getting transported appropriately, but it is unable to regulate the sodium chloride, the channel, the transporter channel. Okay, everything is normal, but the transporter is not responding to the presence of the gene. So grade 1 was there is no gene at all. Grade 2 was gene is producing the protein, but the protein is unable to reach the site of action. Grade 3 is protein is there, it is reaching the site of action, everything is normal, levels are normal, but the transporter, the channel is not able to respond to the genes. Okay, it's unable to understand that what the gene is trying to tell. Okay, then grade 4 is the channel is also fine, but there is reduced conductance. Okay, like the amount of chlorine which should be thrown in or thrown out is less than what it is. So the conductance is reduced. The electric potential is reduced at the channel level. That is grade 4. So it is even lesser severe. Then the level 5 is that the synthesis of CFTR protein is less. Okay, channels are normal, but protein is produced less. And 6 is that the CFTR itself is unstable. So this is how they have classified the cystic fibrosis into multiple levels. Okay, so there are 6 levels, very easy to remember. Last 2 are a bit different, but if you start from 1 to 4, they go in a line. First one has got no protein or no gene. Second one, there is gene, it is producing the protein, but the trafficking is problem. It is unable to reach at the located place. Number 3, the gene is there, the protein is there, everything is normal, but the channel itself is not working out properly. Okay. Number 4 is that everything is present, the channel is also there, everything is working, but the channel is unable to throw out as much chlorine it is required to. So the channel conductance is low. Last 2 are a bit different from the routine. One is the CFTR itself is reduced, it is not produced much, the synthesis is low, and the 6th one is that the CFTR is there but it is unstable. Okay, so these are the 6 ones. Okay. So that this image, I think it's not there in Robin, so 1 to 6 you just write it down. Okay, fine. This is there. So here, as you can see, the level of the CFTR and how badly it is getting affected. If the level is less than 5%, like the CFTR protein is present less than 5% in the body, it shows very severe symptoms. If it is like 50% or more, it's like survival chances are good. So if it is less than 5%, imagine the child is not going to survive more than like 10 years or like 15 years or maybe even less, depending on the amount of infection and all that. Okay. So what are the like organs which are getting affected? One, we know the sweat gland. Sweat gland, it will not cause much of problem because it's only the sweat and the chloride is coming out. The problem is in the respiratory tract, the GI tract and the reproductive system. Reproductive system is also not life-threatening. The only thing is the person will be infertile because like it was, especially in cases of boys, because they have to throw the sperm out, like the semen out, and it needs the normal functioning of the vas deferens. Okay, so the male will be infertile. In case of female, it is not much of implication. And but life-threatening conditions are the ones which is of the lungs or the respiratory tract, because it is completely dried up. So severe lung disease will be there. That is life-threatening. And next the GI, because the motility is affected in GI. So whatever he is eating, especially vitamin A, D, E, K, fat soluble vitamins are not absorbed into the body. Okay, because of that the child has severe vitamin deficiency. Now this gene is very like, you know, it's not like a 0% and 100% gene. It can be present in variety of amounts and it has got lot of loopholes and subholes. So the symptoms may be very varied or very less. No, it's not like that. It will be a mixture of symptoms. So all you have to do is you have to just write it down accordingly, that if the percentage is this, then the symptoms will be severe. If the percentage is this, the symptoms will be less severe, and these are the symptoms when you're writing clinical features. Okay. So fine. You need not, if you want, you can write down all the organs, but expected organs to write is salivary gland, sweat glands, where the sweat is having less of chloride. The next one is the lungs or the respiratory system, where there is severe respiratory distress or there is lack of, the respiratory secretions have dried up. This is the thing you should write. Then the GI, any GI organ you take, write about the motility of the organ. Like it is unable to absorb nutrients, it is unable to make the food go into absorption. These are the most common symptoms. I am telling in very easy words so that you remember, because it's a bit of complicated disorder. Okay, so these things, and for male, infertility. So these are the clinical features, or grossly if you want to write symptoms, is the same. Okay, gross symptoms are not much required anyways. These are infections prone and all, it will be there definitely. So this is not like classic histopathology. This is advanced with some like magnifying colors and all. But all I wanted to show you is in the lungs, when we see, this is the bronchial epithelium. This is not from lungs, this is from bronchus. So this is the bronchial epithelium which has gone for hyperplasia and lot of inflammatory cells. If you see in hyper, lot of inflammatory cells. And these blue things are nothing but the dried up mucus. Okay. Normally mucus is like pink color or something, but here they have dried up. So these are the dried up mucus which is there. This image is an something like fluorescent image, and this is showing bacilli. A lot of infections will be there because once the respiratory system has dried up, infections are very prone. This is a similar image, not much required. This thing is there in Robbins. Okay, clinical features I have told you. This part you can just write the criteria for diagnosis of cystic fibrosis. Okay, as a part of your answer. So I'll just try to make you remember this. So what all you have to remember is, start with the family history. Okay, either the parent is having cystic fibrosis or brother or sister is having. That is one. First thing, you need not write it. It is there in the textbook. Just try to understand this. First of all, family history. Either father or mother has it, or sister or brother has it. So that is one thing which you have to look upon. Then the second thing is, you are suspecting the child because it is running in the family. You are suspecting, so you screen the child and the child is coming positive for the test. Okay. So either of it, like one of the characteristic phenotypic feature is the ones which I told you, that sweat is positive and some of the gut related problem. With that, either one of the parent or sibling is positive, or you have suspected the child to have it, and when you do the neonatal screening you are getting positive. So two of these things is one of the criteria. Okay. With that, either of the tests which is coming positive, just remember this increased sweat chloride concentration. If you can just write that, because the criteria will be too big to remember. So all you have to remember is, first of all, if there is a positive family history, first of all the child is having any of the symptoms. With that, either there is a positive family history or the neonatal screening of the child is positive. Okay. And with that, when you do a sweat chloride concentration test, you get increased chloride. So this is the diagnostic criteria in very simple words. You can write the entire thing if you can remember. I just wanted you to remember this. So this is one thing, you can take a photo or something of this. This is not in the textbook. So what are the laboratory tests or the diagnostic tests you do to find out about cystic fibrosis? So again, it will be similar only like the inborn errors of metabolism. Very commonly we do the sweat chloride test. Okay, you want to write the entire thing, it's up to you, but if you give me the pointers also, it's more than enough. So point number 1, you do the sweat chloride test. Okay, then next, after that you will definitely do the analysis for the CFTR gene. That could be DNA analysis, that could be NGS, like next generation sequencing, or any of those ancillary techniques which we know. Okay, so these two words I would want there. If you are writing the entire chart, it's up to you, but the two things which I want there is, sweat chloride function test has been done, and we do a DNA analysis for the CFTR gene. This is the part of the laboratory diagnosis, apart from the physical symptoms and all of it. Okay, so out of like today's class, 2 questions are important. One is cystic fibrosis, one is phenylketonuria. RDS will be important in your 4th year. That time you will have a big question on RDS in medicine and pediatrics. Okay, fine.